Good afternoon, and you are in session with on WJZZ with Dr. T,
And Dr. Fishta.
and we are so happy that you are joining us today. Today, we are going to be talking about trauma,
Trauma.
the effects of trauma, and we have a guest that will be calling in at around 5:15. It is 5 o'clock, the top of the hour, and we are so glad that you are joining us on In Session. So let's define what trauma is, Dr. Sabi.
So basically, it depends what kind of trauma we're talking about, right? If we're talking about clinical trauma,
Mm-hmm.
usually there is an event or a series of events that take place that are very disturbing emotionally, could be life-threatening, could be a death of a loved ones, could
Right.
be abuse like physical, sexual, emotional, and so forth. We also know from studies that trauma in early life changes the way brain functions.
Right.
And
So basically, we're saying trauma is the psychological response that an individual experiences to a stressful type of event. And we must be mindful that every event is not going to be considered traumatic
correct.
to someone. So trauma is basically based on the individual's response because what you may deem as traumatic may not necessarily be traumatic for me, correct?
That's correct. The perception is a huge factor, and again, there are physiological factors,
Mm-hmm.
and it could be that two people experience the same trauma, and one walks away with PTSD, and one walks away and is not affected as much as someone else. So it's based on individual perceptions, experiences, and so forth. So
Right. So there's a wide, like you said, there's a wide range of emotional and physical effects
yep,
that an individual can experience. So we want to, you touched on a little bit about the types of trauma. And you mentioned that this could be due to like early childhood
yep,
trauma. It could be due to bullying.
yep,
And this is for adults as well as
yep.
children because we do know that adults experience bullying in the workplace. I've actually
That's correct.
counseled individuals that have had conflict at work with bullying, usually by their boss, someone in a higher position. And then we also have community violence
Yep,
by experiencing things that happen in our
yep,
community. It may be a gang fight, it may be a car accident that you witnessed. And
yep,
then we have traumatic brain injury,
yep.
where someone may have a trauma, like a blunt head trauma,
Hmm.
or even coming back from service.
Correct.
We have our service members that may experience what we call post traumatic stress disorder, which used to be called shell shock
Yep,
and a host of other
yep.
names. And then we have complex trauma. And this is something that is new to the DSM about what, a year or two ago that was
A couple of
added
years ago, yep,
into the
2013.
right into the DSM, and this is when someone experiences multiple
Yep,
traumas.
a series of traumas.
Yeah. So then what about disasters, you know?
Yep. We already know from Hurricane Katrina
Mhm.
that there was significant increase in PTSD folks experiencing post-traumatic stress disorder.
Absolutely.
It's a known phenomena. Actually, many disasters around the world, that's one of the major effects that people experience. And then, when we look at even SARS back in 2003, we had those who were infected with SARS in Hong Kong 3.5 years later. A large number, nearly 40% of them, had severe emotional clinical problems, including large numbers with PTSD of those folks. So, and you can look at COVID and see that that's going to have an impact in that way as well.
Exactly. And I think with COVID, that is a type of a traumatic grief that we are experiencing, not just here in Detroit, but all over the world. We have lost so many people,
Yep.
loved ones, political
Yep.
figures, just due to the COVID
Yep.
19. So we're experiencing a global trauma.
That's correct. And you have the global trauma from COVID directly. Then you have the impacts, like you mentioned, the complex trauma. You have the kids in schools. The learning is different. Environment is a separation from friends and others. There could be different kinds of bullying now taking place, given that we are in an online platform environment, which we're still learning about because we really don't know. We've never done it at this level. So
Exactly.
we'll know more in coming months and years, but we're still trying to figure out the impact and in that way. And we already know right now that American Psychiatric Association, they published a study saying that 30% of people in the United States right now are experiencing clinical signs and symptoms of emotional problems. So we don't know how much of that is actually trauma, due to trauma.
Exactly. And I read another article where it says that 60 to 75% of Americans have
That's correct.
experienced traumatic
That's
events.
correct. So we've had consistent studies and surveys coming in anywhere from 30 with American Psychiatric Association. Then you have Kaiser Family and other foundations that are coming in at around 50 or even higher. So, it's fluctuating between 30 and 40, 60% of people.
And it's common for someone to experience at least one traumatic event in their lifetime.
That's correct, and there's different ways to measure the impact this trauma will have. But when you look at signs and symptoms, right, you have the flashbacks, you have nightmares, you have night horrors, and so forth, which is
And even the sweating,
cold sweats,
and even during the day, just being startled or having more hyper arousal or
Yep.
being more alert to different stimuli.
Yep, and when you look at classic PTSD, we have the folks coming back from the wars, right? And they're experiencing, significant number of soldiers are experiencing trauma or PTSD. And while they are in that environment, they function well, they do what they're trained to do. However, when they come from certain areas of war into United States, things are different, and the brain has a difficult time readjusting.
Right, to civilian life.
That's correct. And you
Yes.
remember, we learned more about PTSD. PTSD started taking off with the Vietnam vets. That's how we actually learned the impacts. And even now we deal with folks from Vietnam War who either, severe, significant mental illness or even homelessness and so forth.
Exactly.
Substance abuse and such.
Yeah, I actually recall when I was living in Atlanta, I had a friend and I was visiting, and he had someone there, that a good friend of his that had just come back from, I think it was, I can't remember which tour he did, but at like 3 o'clock in the morning, we heard all this noise and booming, and we went downstairs, and the bed was turned upside down, and he was crouched down in a corner, and he wouldn't let us get near him because he thought he was back in the war.
Correct.
And that somebody was out, and there was sharpshooters outside that were targeting him, and we really had to calm him down, let him know where he is, that he's in a safe place. So this can be something that really seriously impacts a person's life, where it can cause them to not function
In a
properly.
major way, and what you describe in Dr. T is a classic severe trauma, right? Then you have a spectrum or an array of symptoms, because trauma is an umbrella, and within it, PTSD, that is, you have mood swings, you have severe anxiety, could be panic attacks, you have depression, as much as in some rare cases, even a form of psychosis, right? Where the mind basically, in a creative way, yet very unproductive and severe, it kind of checks out, so to speak, in order
Exactly.
to escape these emotions and thoughts.
Exactly. So sometimes they may lose touch with reality.
That's correct.
And even have instances where they want to isolate.
Yep.
And it may look something similar to depression,
Yep.
because there are moments of sadness,
Yep.
and then there may be even symptoms of anxiety where the person just can't sit still, or they're having again these night sweats and the night terrors
Yep.
that cause them to not even want to sleep, so they may have problems with sleep.
Yep. And keep in mind when we talk about isolation, right, which again, COVID has had such adverse effects with respect to the isolation, because once a person isolates, they feel in control, right? They're not prompted to respond. They don't need an energy. They don't need to have this facade that they show the world. So they're kind of in their own space and more comfortable.
Exactly.
However, how long can you keep up with that, and what impact does that have, which is again one of the many symptoms. We also know that, as I alluded earlier, that and the state of Michigan actually has done significant work with trauma, because there is a significant body of research showing that when in early life children experience trauma, what happens, there will be some developmental delay, either be from an emotional, social point of view, or even cognitively, academically, and so forth. And the key to this, according to these studies, is that the earlier you identify trauma,
Yes.
the earlier you diagnose it, the earlier you deal with its impact, the less effect could have long term, so
Long-term
to speak.
effects,
Correct.
exactly. So, if you notice, I have quite a few books on the table. Trauma is actually one of my specialties. And even with, I want to bring this a little bit closer to home with us being mental health professionals. We ourselves can experience secondary
That's
trauma
correct.
from dealing with clients. So,
Yep.
one of the stressors for us is compassion fatigue,
Hmm.
which is basically becoming overly sensitive when working with clients, and now we're viewing their problems as ours, so we're really taking on the role of that client, and we really get immersed with them. So that's something that we want to combat. And then there's also vicarious
Correct.
trauma, which is the trauma we experience from hearing the stressful or
Yep.
traumatic experiences
Yep.
from our clients. Have you ever had a time where you maybe experienced compassion fatigue or vicarious trauma?
Oh, definitely. And as a clinician, as a therapist, psychologist, how you know that it's having an impact on you is if a client walks away from your session, you're still thinking about it for hours after, or even for
Or
days,
days?
right? That's how you know it's having an impact. And if that happens over and over, then eventually it's going to get caught up, right? Because you
Right.
have to function in order to perform work-wise or professionally. So sure, especially when you look at the severe classic PTSD with our soldiers coming back, and the stories are just heartbreaking. Sure, the trauma itself, the events, but most importantly, the way they live life now post-trauma,
Right.
dealing with PTSD, which you can see, for example, you take a person who comes back from a couple tours, and then they go back to college, start living life here. Within a year, two, three, they crash, right?
Yes.
And the impact is relationships, education, work performance, and social life overall, and family relationships are majorly impacted. You can see how things can really take a downturn and have a major impact in not only the person's life, but everyone that's connected to them.
Exactly.
Either be partner, wife, husband,
Or
and
children,
children, family,
co-workers.
neighbors, co-workers, friends. So the impact is beyond that individual, which you see the direct impact.
Exactly. Now we're talking about again trauma and the effects of trauma on our everyday life. We also want to say that some people can even experience denial
Yep.
of even having this mental health condition.
Well, and Dr. T, that's a big one, right? Because denial is an unconscious attempt to avoid what's actually happening, right?
And it's like the brain's way of protecting you.
Defend, right? It's a defense, as the Freudians and the psychodynamic guys put it. What that means is a natural defense in order to avoid something that's happening. The
That's
question
painful.
that's
Yes.
painful emotionally, correct? And the bigger question is, can it be avoided, and how long before it actually has negative impact? So the bigger the denial, the bigger the impact, because it prolongs the engaging in treatment and in being open about it. So some treatment can take place either through therapy means or even some help with medications and so forth. Denial cuts all that out, which can
Right.
have major impact.
Right. Now, some people even experience anger
Of course,
and
quite often,
and extreme
quite often,
irritability.
quite often, and think about the discrepancies in a way a person functions with respect to. With respect to trauma itself, right? So if you and I are sitting here right now and my brain is having a PTSD experience, so to speak, what happens then, Dr. T, is that you and I have no congruency. In the way you talking to me and where my mind is going are two different things. Hence, oftentimes, due to anxiety and depression, anger is a byproduct of that.
Exactly. Now it's 5:16 after the hour, and you are listening to In Session on WJZZ, the coolest radio station in the world. And we have our guest on the line is Cheryl Wilson Smith. Are you with us, Cheryl? Well, I think I did hear her on the line, so I'm going to wait a few seconds to see if she chimes in here. But I do see that she is with us, and Cheryl Wilson Smith is a colleague of mine from out of Pennsylvania. She is a partner in a private practice, and she specializes in trauma. And I believe she has been doing this work for a good 15 years now.
Okay.
So, Cheryl, do we have you with us yet? Not yet? Okay. So we'll just keep waiting until we can engage Cheryl into the call with us, because I definitely want to have her input as we're talking about trauma.
But going back to your day-to-day impact of trauma, Dr. T, taking another example, education, for example, it's once a person is having signs and symptoms of PTSD, and what's required of them is to focus and pay attention, engage in some form of academic performance. That becomes quite difficult because of the flashback of the avoidance and signs and symptoms of PTSD.
Hi, Cheryl. Still not yet? Okay. I know she's here. So we're just going to keep talking until we can get her engaged in the conversation. So we talked about denial, we talked about anger, and then there's this fear that people have with having traumatic experiences, that people are going to think that they are, lack for a better word, that they're crazy.
Well, because again, thinking of trauma, anxiety, depression, mood swings, and all these are all byproducts of trauma, right? And once you start to experience those phenomena, what happens is you feel your emotions are out of control, and you don't know what's going to happen and how life will be, so to speak. So and that provokes and implicates the fear factor, causing your central nervous system to the fight or flight to take over, basically, and that's when it turns into to an anxiety attack and panic attacks and so forth.
Exactly. Cheryl, I'm going to put you on. Okay, so Cheryl?
Yes.
Hi, well, thank you for joining us. We're talking already about trauma and its effects. We went over what trauma actually is and how that has different ranges With your experience, well, actually, tell us our audience a little bit about yourself.
Oh, well, I am in private practice outside of Lancaster, inside Lancaster County, Pennsylvania, and you and I are colleagues, and we did doctoral work together at Walden. So basically, what I'm doing now is in private practice, helping people understand the results or the effects of uh, developmental and shock trauma or episodic trauma, and how someone might be able to take their symptomology that they're experiencing and recover from that symptomology. I am by nature an exposure therapist. I am a certified traumatologist, as well as you are. And so one of the things I do is a lot of psychoeducation and helping people understand what they're experiencing and how we normalize it and how we can help them better understand that it's basically a betrayal of their body in the moment of a trigger. And so I break it down into language they'll understand and ways in which they can use tools and skills to prevent without avoiding or um, subjugating their uh, fears or their stresses or their symptomology, but as a way of looking at their symptomology and experiencing it, and looking at their trauma and experiencing it in a new cognitive restructive way.
So tell us, what are some of those emotional and psychological responses that people are experiencing? We did go over denial, anger, and fear, sadness, but are there some other emotional or psychological responses that people experience?
Well, there are. And we talk about flashbacks. Often here, someone will come in and say, I'm experiencing a flashback. I'm experiencing an hallucination. And so when I'm working with particular types of abuse, someone who's experiencing or had experienced at some point in their life, say, sexual abuse. And so sexual abuse being not just a sexual, it is also the emotional and physical abuse upon the person and their personhood. So what they might be experiencing as a form of flashback might be in the way of a tactile hallucination or a tactile flashback. And so when we start to talk to them about what they're experiencing in that moment, that symptom or that byproduct of the experience, we actually walk through teaching them how to not avoid this feeling, but to lean into it and figure out a way that they can, without abreaction, experience and consider it figured out differently, work through it differently, sit in that uncomfortability that they're experiencing in the moment, and recognizing and having their brain recognize that it's not going to hurt them, it's not going to kill them. And when they go through this process, they start to normalize it for their bodies don't react or trigger in the moment.
So basically, Cheryl, if you're going into the exposure therapy, I believe, where a person actually recognizes consciously the trauma event that they're going through, so to speak, either through experientially or in other ways. Uh, can you tell us some physiological effects of trauma? What's happening to a person when they actually are going through either be an anxiety attack or any of the symptoms that are a byproduct of trauma? What is happening physiologically?
Absolutely. Well, physiologically, the body is reacting to something that has been a stimuli that's been picked up by the brain. And what we know about the brain is that as stimuli enters our brain, it enters all facets of it. It doesn't just enter the executive functioning component or the limbic system. It recognizes the stimuli that trigger all at once. However, there are parts of our brain that react faster than our executive functioning or the cognitive component where we actually can think through things. And that component, that brainstem, the limbic system, gets the information faster and therefore reacts faster. And we end up taking ourselves, when we're triggered, from a place of restfulness to a place of fight, or freeze, or fawn. And so when we look at our experiences and how they cause us to react physically, whether that physical is a shakes or anxiety or nervousness or nausea, flashback, in that moment we can actually start to change how the brain reacts by going through a physical component or a physical breakdown of steps, and teaching someone breathing retraining, or teaching someone how to activate their oh gosh, I just lost the word.
Sometimes that
Their vagus,
happens.
nerve. If we can teach someone how to activate their vagus nerve, then we can actually interrupt what's happening in the brain. So all this information comes in at once to the brain. The part of the brain that works fastest takes over, and the part that works faster is the part that has us running, fighting, fleeing, the oldest part of the brain. So it's going to react faster.
Okay.
And so when that happens, we don't have time to actually think through what actually is occurring.
Right.
And so our bodies react immediately to that stimuli before we can even consciously say what it is. And so when that happens,
So I'm sorry,
body,
Cheryl. I'm gonna ask us, with the physiological symptoms. I've also heard clients say that they've experienced headaches, um, digestive problems, feeling tired, heart palpitations, feeling really jumpy. Do you have that same experience with your population?
yes, yes, I do. Not just the might be even migraines. It could even be anything that causes their body to react to whatever hormones are being sent out by the brain to counteract the stimuli that's being reported to it. So if an individual gets this information, their brain starts to react. The cognitive component of their brain is not fully functional yet because it doesn't have all the information. Your body starts to react, and so then what ends up happening is you might have increased respiratory factors. You have increased circulatory factors. It all stems from this signal that is sent, and then the amygdala inside the brain sends out hormones and signals. We're in trouble, danger, we need to react. And all of these hormones then get flushed into the system, the body. And so what ends up happening is then you have that physiological reaction, whether that physiological reaction is in the stomach and IBS, gastroenterological problems with diarrhea or constipation. You have experiences of people feeling tingly in the fingers because their blood is pulling to the center. This all is a component of that initial stimuli getting and provoking the amygdala into action. So once that occurs, the ways in which we start helping, not just through psychopharmacological agents, but through counseling and through skills-based training. So the skills-based training is designed to eliminate and ameliorate that physical betrayal that happens when we're not truly in danger, but in fact the brain is perceiving danger.
Now, does this happen based on one single traumatic event, or is this something that happens after many traumatic events?
That's a great question. And what we know today is that it can be both. It can be based on a series of what we call minor traumas or small t traumas, or one episode trauma. It really depends on the person's physiological nature, any predisposition to mood dysregulations, So you have all of these factors, and that's why it's really important to do a thorough exam, not just a psychological, biological, sociological exam, but also to bring in that medical component um, before any kind of true diagnosis is made.
Okay. And it is 30 minutes past the hour, and you are listening to In Session on WJZZ, the coolest radio station in the world. And we are talking about the effects of trauma. And we have a very special guest with us, Miss Cheryl Wilson Smith. And she just went over some of the emotional and psychological effects of trauma. And Dr. Fishta, do you want to ask a question or?
I do. Cheryl, sounds like from so much of what you're saying is that identifying trauma, the sooner the better, so work can start, or treatment, other words. Now, can you tell us what are some signs and symptoms that people can look out for in order for them to identify and perhaps reach out for help?
Sure. You know, not all things that happen to us will cause us to go into post-traumatic stress.
Mm-hmm.
So it's really important that we start to recognize those first signs, because those first signs can be very telling on how we are going to experience the trauma later, and whether or not we need to talk about it now or work through it now or work through it later. Many times people don't understand. They go, oh, I had this trauma 30 or 40 days ago, and now I'm experiencing these issues. People tend to not recognize or realize that there's actually this whole component before post-traumatic stress called acute stress disorder.
Exactly.
And so when we talk about shock, that is the initial stages that people will need to look out for. And what happens to the body in shock might be they go numb, they experience headache, they are thirsty, they're dehydrated, they're emotionally exhausted, they are having a hard time concentrating, and so they could also be experiencing nightmares and flashbacks and all of these things that occur with post-traumatic stress, but in the first 5 to 7 days of an event. As we start to go past that first 5 to 7 days, what we want to do is look to see what symptomology is still present, if any. And if it is, sometimes we want to make sure that we don't start treating right away, because some episodic events can ameliorate on their own.
Exactly.
So we don't want to jump into with psychopharmacological agents right away. We want to make sure the person's being cared for in counseling. We want to make sure that person has a supportive network around them, so that we're not jumping the gun and causing anything that might ameliorate on its own through the person's own ability to manage their psyche, but making sure that when they're starting to experience those initial stages, they just keep an eye on whether or not are they experiencing insomnia, or do they have an appetite, did they have an appetite before, are they gaining or losing weight, any kind of disruption in their physical activity.
And
So,
even hair loss. Some people don't even realize, especially with women, because our hair sheds daily. But even experiencing hair loss could be a sign.
Absolutely.
Cheryl,
And
go ahead.
go ahead.
If you're done. If you're not, go ahead and finish. But I also wanted to see if you can engage a bit in the difference between how a child versus an adult actually experiences the effects of trauma.
Well, again, I'm going to go back to making sure that you understand, or that some children, we place this label of resiliency on children.
Mm-hmm.
However, children tend to physically feel their anxiety. They might cry more, they might have stomach aches, they might worry about things that are outside of the event. It really can be, the difference is in how much consumption of trauma did that person receive, how much experience do they have with prior experiences of trauma. Uh,
And their
so,
coping skills that they already have.
correct. So a child might experience trauma in a more physical way.
Mm-hmm.
That doesn't mean you can't have the psychological components. However, children tend to be more supported when there's an event outside of trauma that is uh, maltreatment.
Okay.
So when we think of like a car accident, children tend to be more cared for immediately because of the nature of their age.
Right.
However, we do want to make sure that we are looking at their symptomology and whether or not their symptomology is present, and tends to be, if it's going to be present, tends to be earlier.
Also, we touched up a bit before you came online, Cheryl, about the obvious phenomena now with the COVID, obviously. Can you tell us, based on your experience, and I know we have studies coming in and we're looking closely at the impact on mental health, but can you tell us what are you seeing? Could there be trauma due to it? And we know there has been an increase in domestic violence and substance abuse and some of these issues that we are already aware of. But based on your experience, what are you seeing, Cheryl?
That's another great question, and I think it's really important factor in separating this type of trauma and symptomology from typical post-traumatic stress or acute stress disorders. I do think that we might see later down the road a diagnostic and statistical manual of mental disorders clearly showing some type of anxiety induced from pandemic.
It's funny you say that, Cheryl, because they're already coming up actually with instruments to assess the impact of COVID on emotional status. Very recently, we've had some screeners, so to speak, that are screening directly for COVID. So very interesting you bring that up. But go ahead.
Based on what I'm seeing in my own practice, I have an influx of people who have never had any mental health concerns prior and suddenly are now experiencing fear of leaving their homes, agoraphobia,
Mm-hmm.
fear of
Being in large
that,
crowds.
yes,
Has that been something you've also seen, that they are afraid to be in large crowds?
that usually comes when there's a direct indication. When I see something like that, where somebody's coming back from combat or somebody is experiencing a generalization of their fear, I am seeing more people stay inside their homes. I've not really had anybody based on COVID-related disorder or COVID-related depression or COVID-related, and that's not a clinical term, but that's the term we're using in the office to really between somebody coming in who has distress based on depression that they've had prior, or suddenly they're having depression based on the fact that they've never had an issue going to work or losing their jobs. Then we're getting an influx of people who have no health insurance, who have can't afford health insurance. They've lost their businesses. Mm-hmm. They've lost their livelihood. They've lost family members.
Yep.
All from this, and it might not just be dealing with the hospitals and doctors, nurses, and the COVID-related practice of getting someone better. However, it also can include, and what we've seen is those things that they hear or don't hear based on media consumption. Mm-hmm. And so having someone come in for the first time, or having a telehealth appointment for the first time with somebody who's explaining, I was told that I was going to be safe. I did my daily life, or I'm afraid to go outside my house. I'm afraid to go to the grocery store. I'm afraid to go to the mall. I'm afraid to go get gasoline in my car. I lost my job because I'm afraid to go and pump my gas. That's something that someone actually said to me.
Oh,
So,
wow.
you know, all of these fear-related distortions are occurring based on misinformation, not enough information, and trying to get accurate information out to the public has been such a challenge this year. And so, making sure that those individuals who have underlying conditions know exactly what can happen physically, and then dealing with the emotional response that goes with the lifestyle change. And
Now,
the multiple people I've had are people who are experiencing COVID-related lifestyle changes. And it's causing the secondary depression, it's causing the secondary anxiety, where their anxiety and depression wouldn't be there if not for COVID.
right. Now, let me ask about trauma and memory. Have you noticed when some people experience trauma that there's always the negative thought from behind the trauma? How do you help to basically like rewire the brain to change those negative thoughts?
So when I hear you saying you're talking about cognitive restructuring,
Mm-hmm.
and cognitive restructuring is an older tool that we've all learned about, I think, in our mastered programs, CBT. And so, as a component of CBT,
Cognitive
cognitive,
behavioral therapy you're referring to, correct?
correct,
Okay.
cognitive behavioral therapy.
Just for the
Um,
audience, the listening
Yes,
audience who
yes.
may not understand those
Yeah,
acronyms.
yeah.
right, and I apologize.
It's quite all right,
So,
Cheryl.
um, so yes, cognitive behavioral therapy. There's a component called cognitive restructuring, and that is basically rewiring someone's thought about their trauma, their feelings about their trauma, as a way of better understanding how it was incorporated into their bodies, into their minds, into their brains when it happened, how it occurred, what age it happened. So if I have somebody who perhaps was injured sexually at age 10, they might start to experience latent recovery of memory when they're older.
Mm-hmm.
And it's a place where they now are safe or secure in order to start having their brain release this information, the memories to them. And they suddenly come into counseling for the first time and go, oh my God, I had this memory of this event. And so what we do is we'll use the sexual trauma inventory and determine how someone has actually incorporated what happened to them, how they felt about it at the time, if they only remembered it now, what do they remember, what do they recall, who is this person to them, and how did they blame themselves or did they blame someone else? How did they incorporate what happened to them? And so once we get a better idea of how it was incorporated into their life or how it happened, we can then determine the best way to take this information and share with them how they've incorporated it and how they should now look at the information. And how we do that is by going through exposure mechanisms. And that can be done with EMDR, that can be done with prolonged exposure. And so when we start to use those two mechanisms, those two theories, those two therapies, we can actually start to change how someone considered what happened to them. It literally is the rewiring of cognitive processes, through neuroplasticity. It is having someone perhaps maybe narrate what happened to them in a different way.
Mm-hmm.
With exposure, we would actually take someone, teach them how to ground themselves so that when we start to talk about what happened to them, we can actually have them narrate what happened to themselves in a way as though it were happening not in the past, but in the moment, and using not the child brain that it happened to, but their adult brain now to make a better sense of it.
You know, Cheryl, I get so excited to hear you talk, and let me tell you why. Because the way you describe this, it gives this sense of hope that there are things that actually can be done. Because, considering a person who has trauma, it's very difficult to start therapy, right? Because they think, once I go there, I'm going to dig into pain versus walk away from pain. It's just easier to oftentimes give me some medication so I can go on with my life and not have to deal with this. So, but sounds like you're saying there's so many ways that you can approach this that can actually work and can minimize the effects of trauma.
Right. And before you get started, you are listening to WJZZ Cool TV, and we are this session is we're what in session.
In session.
And WJZZ is the coolest radio station in the world, just in case you all didn't know. And we are talking about the effects of trauma with Cheryl Wilson Smith.
And Cheryl, I want to extend a bit on what I said earlier. Given that you do this for a living, actually, you're seeking those who are suffering from trauma, and often you see them in your office or offices. Can you tell our audience what can someone expect the first time they see you, or a therapist, so to speak, so people are not frightened, or a counselor, which is the same thing, obviously. What can people expect?
That's a wonderful question. I'm so glad you asked it. When someone comes into my office, and I can't guarantee what someone else will experience in someone else's office, but when someone comes into my office, one of the first things they're going to do is they're going to find that it's a safe location. It's not, my office is within a building office. They park their cars. No one's going to be able to see or know what business they're going into. I have a lobby where people can have coffee or tea or water and then just relax. There's always some kind of soothing music or television show that's on that is meaningful in the moment. Now with COVID, things are a little bit changed because they're doing a lot more telehealth. However, one of the first things that they're going to do, they're going to receive from us, is the Taylor-Johnson temperament analysis. And
now what is that?
Gives, I'm sorry?
Say what was that again? The Taylor-Johnson?
Yeah, it's the Taylor-Johnson Temperament Analysis, or the TJTA-2. This temperament analysis gives us a baseline for someone who's coming in. It's 180 questions. It's taken on the computer. It takes about 45 minutes at the most to take. And we offer this to our clients as a way of measuring what the clinician is doing. And so, is what we're doing actually working? And this is the we go about measuring our outcome.
Okay.
So, they take the TJTA and they can take it. We send a link to them so they can take it long before they come in and see us, so that we typically have the results the first time we see them. Then we also provide them with the PSSI-5, and that is the instrument we use to help guide us in diagnosing post-traumatic stress. It's a symptomology scale from Dr. Edna Foa, and so and it's 5th edition. And so we utilize that scale as a way of determining what is the symptomology that someone is experiencing and to how often they're experiencing it. Now, the PSSI-5 actually offers us a duration as well. So the duration of this might be, it'll ask more than 30 days, less than 6 months, things of that nature. So we give someone that in paper, pencil form. If somebody's coming to us and saying, I'm coming into counseling and I'm experiencing loss of time, there's things that are in my closet that I don't remember purchasing, we would then also provide the dissociative experiences scale too. And that dissociative experiences scale just is a reminder that everybody dissociates from time to time. There is a percentage of the scale, and it just asks us how often are you experiencing the dissociation. And so there are those components. And then if somebody's coming in with comorbid or co-occurring disorders, we might also offer the DAST or which is the drug assessment, the drug and alcohol symptomology, or the screener test. And so we might offer something that's going to help us determine, is someone using drugs and alcohol as a way to avoid or escape from their traumatic feelings or the traumatic responses that their bodies are going through. And oftentimes people start to eliminate their alcohol or drug use based on the fact that they've had unresolved trauma. And once that trauma is resolved, there's no longer a need to self-medicate. And so it's much easier for them to become sober or clean.
So not only sounds like, Cheryl, you assess trauma for diagnostic purposes coming into the office, but you also measure outcomes of the treatment that you or your team is providing. Do I hear that correct?
That's accurate, yeah.
Now, sure. I wanted to ask you one last question before we get off of here, because we have about 4 more minutes before our show concludes. But there has been some studies that has stated that there is a change in the DNA for someone that experiences trauma. Not necessarily that the DNA itself changes, but the way that the cells and the organs actually communicate with each other. Are you familiar with anything of that nature?
I don't recall reading the changes in DNA and how trauma causes us to evaluate the connection between organs. I will say that I have read several studies on the generational component that is carried down through our DNA of the likelihood of anxiety. And so if we're predisposed to post-traumatic stress through anxiety mechanisms, it could be that neural pathways that are defined by a traumatic episode or traumatic event can then be carried down through the womb to the next person, the next child, as a structural component, as a way. And so, there are ways that we look to regrow the hippocampus through neurogenesis. There are ways we try and move and change that so that if we start to change how trauma has changed the neural pathways of the adult, of the female or the male, then we can then cease it from occurring in future generations. However, that does take us recognizing that trauma affects and can be carried down through parentage. But again, I'm not familiar with your study. I am familiar with the anxiety, the reproduction of anxiety through inner utero.
Okay. What I'm referring to is something called epigenetics that has been studied, I guess, for about 5 years now. So there's a few studies that have linked heredity or hereditable phenotype changes that again does not necessarily change the DNA, but the way that cells and organs and communicate with one another. So and it
Well,
tends
I
to
think,
deal more with the with external and environmental factors of the individual.
I would say it stands to reason that that study would be accurate based on the fact that, we know so much more about the DNA molecule than we've ever known before. So if you're talking about epigenetics and the alteration of physical structures, then it stands to reason that it is a possibility that when we're looking at the severity of trauma, the changes to one over a period of time. In other words, someone might be more disposed to more severe mechanisms of trauma, dissociation, over time. So their child might be more prone to dissociate as opposed to have that, because the part of their parentage, the DNA says dictates that this is a phenological component.
Which I believe, Cheryl, you mentioned earlier that working through that neuroplasticity is a way to combat that. Because, sure, we have studies on epigenetics with where they used mice and they injected fat in mice where then the other mice were born overweight, so to speak. But also, I believe through neuroplasticity, the pathways could be altered for the better.
Yes, and we talk about neurogenesis
Yep.
through that, making that change, neurogenesis.
Yeah.
And in my practice, we talk about the three main components of working with trauma and
Oh
amelioration
my
of.
goodness. I wish we had more time to really go into that bit. Our session is actually over for today.
Cheryl, thank you so much for being in our show.
And we're going to
You're
have to
welcome.
have you back too. We're going to have to have you back. This was a very interesting conversation. I want to again thank you for coming in. You all have been listening to In Session on WJZZ Cool TV, the coolest station in the world. And next week we will be talking about spirituality and mental health. And if you are interested in advertising on WJZZ or want to be a sponsor of one of our shows, please call us at 313 365 6018. And I hope you all have a wonderful week.